Hello everyone and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples listening today or in the future. My name's Rebecca. I'll be facilitating today's webinar on alcohol use in pregnancy. This webinar is a part of a series, Connect and Learn webinars designed to support AOD clinicians throughout Victoria. The webinar series is funded by the Victorian Department of Health and hosted by Turning Point. We do want the webinar to be as interactive as possible, so please use the Q&A, not the chat function, to ask your questions. I'll collate those questions and I will put those to the presenters at the end. Anything you miss, again, can be found on our website in the coming weeks. We encourage you to stay to the end of the webinar, complete the survey. There'll be a QR code that will appear towards the end and nearer the Q&A section. We will also send it out with an email later today. I'll quickly introduce our presenters. Associate Professor Yvonne Bonomo, Dr. Anna Totman and Julie Blanthorne, all from the Women's Alcohol and Drug Service at the Royal Women's Hospital. Thank you so much for joining us. Yvonne, I'll pass it on to you. Thank you.
Thank you. And let us start. So managing alcohol use and alcohol use disorder in pregnancy. I'll speak firstly from an addiction medicine point of view, and then we'll have our paediatrician, Anna, speaking, and Julie, our midwife, talking about breastfeeding and alcohol use. The key message from today is that there is no level of alcohol in pregnancy that has been shown to be safe. And that is a key message that we need to get out to the community so that everyone understands this very important concept. Of course, people will ask, when one says that there's no safe level, people will ask, well, what if I have one drink, or if I've had one episode of binge drinking, what's my risk of impacting on the pregnancy then? We don't really know. That's being looked at the moment, but the risk does appear to be low with low alcohol intake. However, it can vary between individuals, and that's the nature of the conversation that needs to be had with women who are pregnant and who are considering drinking alcohol. The other key message is to not avoid antenatal care. We know that women who use alcohol and drugs tend to shy away from attending antenatal care because they're scared, they're worried that they'll be reported to child protection. And really what we need is time to address the broad range of issues that emerges with substance use. So the sooner they can turn up to antenatal care, the more time we have as healthcare professionals to provide the support they need and help them achieve the goals that they want to achieve. The message about there not being a safe level of drinking in pregnancy is getting through to the community, so that's a really encouraging sign. You can see here that since 2007 up until the most recent National Drug Strategy Household Survey, the number of women reporting drinking in pregnancy has progressively declined. So that's very heartening for us. And this is the reason why it is so important that we get the message out. So alcohol is a teratogen. That means it impacts on the development of the baby or the fetus. And you can see in this slide here that from already weeks 3 through to week 16, the key organs that are developing are the brain, the heart, the eyes and the ears. And so that is why those organs are affected. You can see here with this red bar here, why they are affected when alcohol exposure occurs in the early prenatal period. So Anna will talk in more detail about that, but we wanted to put that up front and centre because it's so crucial to understanding why we need to get the message out to the community that there is no safe level of drinking during pregnancy. In terms of prenatal alcohol exposure and the question I referred to before about, well, you know, what if I have just a little bit? Well, what's the likelihood of that affecting my baby? That's currently being studied through the AQUA study, which I encourage everyone who's listening today to follow. There are publications coming out from the AQUA study led by Evelyn Mugley. It's a longitudinal study here in Melbourne, and they're looking at prenatal alcohol exposure and different types of alcohol exposure prenatally. And so, for instance, one paper they've published shows that there are subtle craniofacial changes at 12 months, and that picture there is just to show you how subtle it can be. Whether that has clinical significance remains to be determined. The group are following up this cohort of young children and their mothers. At 2 years of age, they found no significant association with neurodevelopment after adjusting for confounders, but they are continuing to assess the children, and we will learn more as this study progresses and understand more about the lower levels of prenatal alcohol exposure and what effect they might have on the developing child. The NHRMC guidelines for the treatment of alcohol problems has just been updated in the last year, and in those guidelines it categorically states that to reduce the risk of harm to the unborn child, women who are pregnant or planning a pregnancy should not drink alcohol. And for women who are breastfeeding, not drinking alcohol is safest for their baby. And those guidelines looked at the literature that's available in this area and have assessed that literature and come up with these recommendations, which are not dissimilar to the previous ones in the case of pregnancy and breastfeeding. So that leads us to how do we screen for alcohol use in women who are pregnant? And when women present for their antenatal care, there's a whole lot of things that need to be asked. And so alcohol use is just one of many, many things to ask. The Audit C is a tool that is validated and has only 3 questions. So it's a contracted version of the audit tool, which is 10 questions, but very helpful in determining whether you need to explore further the nature of the alcohol use in that particular woman. So you can see the 3 questions there and the scores next to the questions and the answers. If a woman scores 3 or more, it indicates that you need to explore further. It is not diagnostic of an alcohol use disorder. It is merely a flag that says, okay, you need to ask more questions, find out more about the pattern of drinking, when it's happening, how much, etc., what are the triggers, and so forth. So a screening tool, not a diagnostic tool, nonetheless very helpful. Now, if on doing the Audit C, you determine that the woman is not dependent on alcohol but is drinking in pregnancy, what does one do? Well, brief intervention helps. And so the guidelines have recommended, and it's level A evidence, that from the studies that have been done looking at brief intervention, it does have a benefit for those who are not dependent on alcohol. It can help reduce that alcohol consumption. And so an example of one approach to brief intervention is using the flags method, which is providing feedback on the pattern of drinking presented. So you take the history and then reflect it back to the woman to explain what you've understood as the pattern of drinking, because often the woman may not have thought about it until she's talking about it with you. Feedback on the guidelines, listening to her about and encouraging her readiness to change, advising unequivocally about the advice to not drink, and then setting goals to achieve that and strategies, practical methods for achieving that goal. I do underline the unequivocal advice because we are aware that there is a tendency amongst health professionals to play down the impact of alcohol, and we need to be quite clear that there is no safe level of alcohol consumption during pregnancy that we are aware of at this stage. Other additional things to help with brief intervention are resources such as Women Want to Know, which is a very good website, and I encourage you to access it. It has lots of resources there that help you with the language around how to talk about alcohol and pregnancy, the kinds of questions to expect, the kinds of answers that you can provide, and also some written advice. And similarly, No FASD Australia website has wonderful resources that you can access and that parents, carers and families can access as well. So all these websites, and of course I'm sure you're all aware of the fair advertisements that are out at the moment with the slogan "Every moment matters," encouraging women who are planning pregnancy to stop drinking. So there's lots of information available for both the woman, her family and carers, and also ourselves as health professionals to access, so that we've got the right words to say and we can anticipate the kinds of questions we might get asked. At WADS, we have a FASD doll, as you can see there, which helps during consultations to talk about the different effects that alcohol has on the child's face and the child's development, and Anna will go into that in more detail later. So what if the woman is pregnant and presents intoxicated with alcohol? What is the recommendation there? Well, this is addressed in the guidelines, and it's a good practice point, meaning that if a woman presents intoxicated during pregnancy, the advice is that an assessment of fetal safety, maternal safety, and essentially a comprehensive assessment and care planning is done. There's not evidence to support that in terms of randomised controlled trials and so forth. It's just a good practice point. It is an opportunistic time to talk to the woman about the nature of how she became intoxicated. Is this a one-off event, or is this something that has been recurring, and then taking it from there. In terms of alcohol use disorder, again, Chapter 14 of the guidelines talks about this in more detail. But before going to those guidelines, it's important to remember that there are a lot of barriers to care in pregnancy that prevent the woman from coming, and that's why we need that message to get out there, not to be frightened, but to actually come to antenatal care. So social stigma, fear of losing custody of children, lack of availability of services, where to go, or it being difficult for her to access those services, particularly during times when she might be looking after other children. We're aware that partners often don't want the woman to attend services, so there's another barrier there. And the siloed treatment of mental health versus primary care versus drug and alcohol care versus pregnancy care, all those silos don't necessarily integrate nicely and work well for the woman, so she could be spending most of her time attending appointments, which creates a barrier for her to attending for help that will get her to reach the goals that she's after. So for that reason, for all those barriers, we often see women presenting quite late in pregnancy, and as I mentioned at the start, we want them sooner rather than later, so that we have maximum time to work with the woman to help her achieve her goals. Now, in terms of managing alcohol use disorder specifically, it is imperative that it's supportive. So recognising that there's stigma, there can even be self-stigma, feeling ashamed about the alcohol use. Having a support person is really important for women as they progress through pregnancy. Multidisciplinary care, we know, works better than just a single discipline being involved. Trauma-informed care, of course, is imperative. Being able to accommodate the woman and other children in her care, should that be the situation. Not castigating the woman about relapses, but preparing her that there may be relapses to alcohol consumption during the course of the pregnancy, but being able to nip it in the bud as soon as it happens is important. And then ongoing monitoring of the baby, and not just immediately postpartum, ideally through the child's formative years, so up to school age and even beyond, but certainly the first 1,000 days, so that important period of early human development from conception to the end of the second year of life is very important in terms of switching genes on and off during that time that then affect that baby, later individual's life trajectory, moving right through to adulthood. So, for instance, we know that breastfeeding and nurturing switches off the genes for the stress hormone, the glucocorticoid hormone, and helps reduce stress levels. So that's the kind of thing that's happening early on. And if stress systems are turned off early on, then the nature of that person's health throughout their life is going to be quite different to someone who's biologically primed to respond to stress. Managing withdrawal from alcohol in pregnancy needs to generally be supervised because abrupt cessation can be dangerous, particularly if heavy or high amounts of alcohol are being consumed. Using diazepam is safe, however, in moderate to severe dependence. Of course, we need to include thiamine because people who drink heavily do not absorb their thiamine very well, and be aware of other vitamin deficiencies that are important in pregnancy, including folate deficiency and others. Of course, withdrawal or detox is never the actual treatment. It's the beginning of, or the first step for longer term treatment. But bear in mind that withdrawal is a state of physiological stress. The system is, the pulse rate is up, they're breathing more rapidly, the blood pressure is up, and that's why the woman needs supervision so that that process of withdrawal is as smooth and as physiologically calmed as possible, because what mother's feeling, baby will be feeling as well. And for that reason, we need flexible services for withdrawal and rehab that cater for the pregnant woman so that she can do her withdrawal, feel comfortable as possible as the alcohol comes out of her system, and then move on to the next stages of care. And then maintaining abstinence. Of course, there are 3 pillars to maintaining abstinence. The first pillar of addiction treatment one considers is pharmacotherapies. When it comes to alcohol pharmacotherapies in pregnancy, this is from the guidelines, they cannot be routinely recommended during pregnancy due to insufficient safety data. So that grade of recommendation is level D, meaning that animal studies have shown abnormalities, but there aren't enough human studies to be able to be completely satisfied that there's no risk. Having said that, I've written in red there, if one has to weigh up whether the benefit justifies the potential risk of alcohol exposure to the fetus, and informed consent is absolutely essential. So talking with the woman about the role of pharmacotherapy, whether she feels that it would help her, and the fact that there isn't a lot of data available at the moment, and weighing up those particular considerations. The second pillar of treatment is psychological or behavioural strategies. No particular method has been shown to be superior in alcohol use disorder. So it's really a case of what suits the woman at that particular time, what she's most open to and what's available, and what she's most likely to engage with. And then, of course, the third pillar is the psychosocial context, because if that woman is living in a situation of family violence and in fear of her life or her children's lives, or if she's living in poverty, or if there are other stressors, then all the medication and all the psychological and behavioural strategies in the world will not work until this aspect of the woman's life she's being assisted with that aspect of her life. So in the postnatal period, I'll just flash this up in the interests of time. In the postnatal period, one might consider pharmacotherapies because the baby's now been born, and if she wants to breastfeed, you can see there that naltrexone is considered safe in breastfeeding, but I'll leave the breastfeeding commentary to Julie. And just to give a teaser before Julie's talk, to show that more women are choosing not to drink not just while pregnant, but also while breastfeeding. So again, really encouraging that message is getting out to the community and women are taking it on board. If you're not sure, or if you wish to discuss plans around a pregnant woman with alcohol use disorder, there's the WADS number and the email. Feel free to give us a call, and we can talk through with you what the potential treatment options are, or what things to consider that you might not have thought of, or indeed to confirm that your plans are very much on track. So with that, I'll hand over now to our paediatrician, Anna.
Thank you very much, Yvonne. So I'm going to talk about fetal alcohol spectrum disorders and the impact of alcohol on the fetus and the developing human. So alcohol diffuses freely from the maternal to the embryonic or fetal compartments. It's a small molecule and it can move freely across the placenta. And the embryo and fetus is much worse at eliminating alcohol than the mother is. So in the adult human, in you and I, the major pathway for the breakdown of alcohol is alcohol dehydrogenase. But actually, that pathway isn't developed in the fetus until into the third trimester. In the embryo and the fetus, it's cytochrome P2E1 is the major metabolic pathway to break down alcohol. And this produces reactive oxygen species, which can then damage the developing cells and particularly the lipids around them. That pathway for alcohol breakdown is expressed mostly in the placenta through the early part of the pregnancy, but also in the brain. So the majority of alcohol breakdown in the embryo happens in the embryonic brain from 6 weeks to 16 weeks of gestation. And the liver takes over at around 16 weeks of gestation, but the alcohol dehydrogenase pathway doesn't come into play until around 26 weeks of gestation. So a different pathway for alcohol breakdown in these fetuses. We could move on, please. The message that no amount of alcohol is safe in pregnancy is really important, and it's important because there are so many other things that can determine when an embryo or a fetus is damaged by maternal alcohol intake. Depends on the timing of that intake. So if you hit one of these crucial developmental windows, that's much more damaging than being in a less crucial time frame. The dose, so binge drinking, particularly in the first trimester, can result in women having a very high blood alcohol concentration, much higher than somebody who is drinking every day. And that, of course, is then passed on to her fetus. And concurrent stressors. What I mean by that are things like poor maternal nutrition, other drug use that might be impacting the fetus's ability to clear alcohol, and poor placentation, so a placenta that's not able to provide enough nutrient or oxygen to a fetus and thus is already in metabolic strife. What we know about the embryonic and fetal effects comes from a number of animal models, and you can see here an embryonic zebrafish, which are nice to study because they are see-through, and the baboon model has also been used. But we know that in the embryonic period, alcohol exposure to the embryo causes apoptosis of neural crest tissue. So that's the tissue that is forming the fetal brain, the embryonic brain. But it also forms the midface, and that's where you get to see the cardinal signs of fetal alcohol spectrum disorder in the face, is that whole developmental pathway has been disrupted. We know that alcohol causes oxidative stress to a fetus, and we know that it causes placental vasoconstriction. So the fetus is dependent on the placenta for its oxygen and nutrient supply. And if the blood vessels in the placenta are constricted by maternal alcohol intake, that fetus will not be able to get the nutrients and the oxygen it needs, and that increases the fetus's risk of being growth restricted, to be born too early, to be preterm, and also to suffer a hypoxic ischemic damage during the birth process. We also know that alcohol can make epigenetic changes to the developing embryo and fetus. So it doesn't change DNA, but it changes the way that genes are expressed. And this can, as Yvonne has said, increase a child's susceptibility to stress and addiction and other disorders throughout the life course. As I've said, the effects on placentation can lead to neonatal effects that we see in the babies. So prematurity, being born before 37 weeks of gestation, low birth weight, both of which are independent factors for long-term poor neurodevelopmental outcomes. Low APGAR scores, so a baby who is born with a potential hypoxic ischemic injury, and if you have a placenta that is not working well, the birth process is the most stress that's going to be put on that placenta. So these babies are high risk. After they're born, they can display poor behavioural state regulation, abnormal sleeping patterns, and poor feeding. There is a little bit of controversy about whether alcohol in itself causes a true neonatal withdrawal sequence, but it is reported in the literature. The onset is described to be within 12 hours of birth, and babies are reported to be hyperactive, irritable, to have a poor suck, to be tremulous, sweaty, and to want to take very high amounts of nutrition. And those symptoms have also been described as being long-lasting, up to 18 months. Now, it's a little unclear as to whether this is a true withdrawal sequence or whether these are the neurobehavioural changes that one sees with a baby who has had exposures throughout the fetal period. Either way, one needs to be cognizant of these when you're looking after children who have been alcohol exposed. Later on, we talk about children who have fetal alcohol spectrum disorders. And this slide that I'm showing you now comes from some of the literature around how we used to make the diagnosis in children in Australia. This gives you a number of levels, I guess, of degree of severity of fetal alcohol spectrum disorder. But actually in 2016, we were gifted with the Australian Guide to the Diagnosis of FASD, which we'll see on the next page, revised in 2020. And so a diagnosis of fetal alcohol spectrum disorder requires evidence of prenatal alcohol exposure, so really important that we have that documented, and severe impairment in 3 or more domains of central nervous system structure or function, and subdivides this into 2 further classes. You can have FASD with sentinel facial features, 3 sentinel facial features, or FASD with fewer than 3 sentinel facial features. And again, if you recall, the sentinel facial features come from a period of damage when the brain is also forming. So you can tie the 2 things together. This comes straight from the Australian FASD diagnostic guideline. And you can see that only with 3 sentinel facial features are you able to make this diagnosis with an unknown prenatal alcohol exposure. And that can become very difficult because in some studies, less than 10% of children who are known to have FASD actually do have those facial features. Again, it's around a critical timing of that developmental impact that can make the changes to the face. And one needs to have severe impairment in 3 domains to be able to achieve the diagnosis. And from my point of view as a neonatologist, I deal with children under the age of 2. It's very, very difficult to assess children, in fact, for these criteria, really under the age of 6, to be able to make a true diagnosis. And at the moment, the FASD hub in Victoria doesn't take referrals for children under the age of 3. So we have a group of children out there who we know have very heavy alcohol exposure, but that we can't yet make a diagnosis for. These are the sentinel facial features. So hypertelorism, so the small eyes, and having the slightly rounded appearance to the eyes. And then the classic one that people talk about is the smooth philtrum and the thin upper lip. And there are grading scales to be able to assess philtrum thickness and upper lip size. Having said that, the majority of them are in white children. There are very few resources available for the diagnosis in children of other ethnicities, and certainly not for children of Aboriginal ethnicity, although I know that there is some work in the pipeline around that. And again, you will see this is not a newborn, this is an older child. Long-term, children who have been exposed to alcohol prenatally have a number of poor outcomes, so they are less likely to achieve tertiary education and are more likely to have difficulty with their education throughout the life course. They are more likely to be underemployed. They have a higher rate of mental health disorders than the rest of the population, and they have high rates of contact with the justice system. And a study about 10 years ago in New Zealand found that somewhere near 25-30% of youth offenders coming up into court on any one day had undiagnosed FASD. These children end up themselves having high rates of substance abuse. And because of the fetal impacts of maternal alcohol use and the restriction of nutrients and oxygen via the placenta, these children are also more likely to have higher rates of diseases of fetal origin. What do I mean by that? Well, diseases like obesity, hypertension, insulin resistance, diabetes, diseases that are programmed by the fetal environment are more likely to occur in these children who have had an adverse fetal experience. And FASD is a lifelong disorder. So the primary symptoms are those from an acquired brain disorder, and that's secondary to the neurotoxicity of alcohol. But the primary symptoms affect the way that the child interacts with their environment. This can be an adverse relationship that they then have. For example, a child who has hyperactivity symptoms, secondary to their FASD brain disorder, who then is in a classroom and is told that they're naughty and they can't sit down, so they hate school, so they bunk off school, so they get into trouble. And then you get into the secondary symptoms: poor education, contact with the justice system, poor family relationships. And unfortunately, we know that children who go to families where one or both parents is a substance user, in this situation, they're less likely to be getting the consistent parenting and the highly structured environment that would most benefit these children who have an acquired brain disorder. We know that these children need to be scaffolded by their environment to be able to promote the best neurodevelopmental outcomes for them. And yourselves as AOD workers, you will be seeing adults who have probable FASD, who come from backgrounds where they have been exposed to alcohol in utero, and their relationships with you and the way that they engage with services will be shaped by this acquired brain disorder. So I'm going to move on to pass over to Julie shortly, but just if anybody's interested in more information, the FASD Hub has some great resources that are available for everybody to look at.
Thanks, Anna. Always a great talk. So I'm Julie Glanville, I'm a midwife at WADS at the Women's Hospital, and today I'm going to be talking about breastfeeding in the context of alcohol use. So as Yvonne said, the NHRMC guidelines state that abstinence from alcohol is the safest option, particularly in the first month after birth until breastfeeding is established. So it takes about 4 to 6 weeks for milk to establish. So it's best not to use alcohol in that time. So we know that breastfeeding is very important in all women, but particularly in this population, because we know that often the women are not are particularly healthy, and it's very important that they give the most important essential elements of breastfeeding for their babies if possible. So we know that breastfeeding transfers essential immunity, and that oxytocin is a feel-good hormone, and this helps induce bonding, and it allows the mother to feel that she is helping her infant, which only a mother can do. And it's all very much tied up with the woman's desire to be a good mother, which these women very much desire. And it reduces the risk of SIDS and also allergies in the children. And breastfeeding is recommended for at least 6 months of a child's life. So in WADS, we know that breastfeeding is actually not that popular, but it's certainly more common and popular amongst women who have come for antenatal care than those who have not, because we do childbirth education individually with women. So with alcohol in breast milk, so as Yvonne and Anna have said, so it is about the molecule, the alcohol molecule is very small and it's water soluble. And so this makes it be able to pass readily into the maternal milk. And alcohol level is the same in the breast milk as it is in the maternal blood. So if a woman's blood alcohol is 0.05, then that is the same level as in her milk. It's also 0.05. And the peak concentration occurs after 1 hour of ingestion. but is delayed if you consume food. So that's why we would always suggest that women breastfeed first and then have a drink. And alcohol bioavailability is around 20 to 25% lower in lactating women. And so that means that the peak blood alcohol level can be delayed for up to about 30 minutes. So it might be a little bit slower getting into the system than women who are not breastfeeding. So do many women drink while they are breastfeeding? Well, yes, they do in Australia. So around 50 to 70% of breastfeeding women drink alcohol in Australia. So the studies show that they're more likely to be married women, educated, older, with higher incomes than those who abstain from alcohol, more likely to be employed and from an English-speaking country. So usually the women are drinking less than 2.6 standard drinks a week, and they know that it is important to feed prior to drinking alcohol. And they're usually drinking about 1.6 standard drinks at each drinking session. So within a non-pregnant woman's, the NHRMC guidelines for safe drinking. So these studies have also shown that drinking while breastfeeding does not affect breastfeeding duration. So there was a concern that women were stopping breastfeeding because they wanted to start having a few drinks, but in fact that isn't the case. But very concerningly, they are still serving alcohol with meals in private hospitals despite the NHRMC guidelines. And once we have actually written to hospitals just alerting to that, and especially because it is not recommended, particularly in the first 4 to 6 weeks. And we know that antenatal education is very, very important for women. So as Yvonne was saying, we always ask women about alcohol when they first come to their booking at the hospital, and then talking about breastfeeding and alcohol consumption is also important. So how much is the baby actually getting if a woman is drinking alcohol when she's breastfeeding? Well, it is quite different to pregnancy. So as Ada said, basically when a woman has the drink, so a glass of wine, which is say 12% alcohol, and she's pregnant, she's essentially giving that wine or that drink to the baby. So if a woman's blood alcohol level is 0.05 when she's pregnant, her baby's blood alcohol is also 0.05, although it might even be more than that because of those immature systems in the developing fetus. But when you're breastfeeding, as I said, the milk has got the same amount of alcohol in it as the maternal bloodstream. So if your blood level is 0.05, your milk's level is 0.05. So that baby's not getting a 12% alcoholic drink, it's getting a 0.05% drink. So when women have very low levels of drinking and can time feeding around alcohol, we feel that this is best for women to know this as a sort of a way, as a harm minimisation strategy. But it's very important to remember, as Anna said, that the liver of newborn infants is also very immature. And so sometimes those babies can actually hold on to the alcohol. They don't get rid of it as quickly as an adult. So yeah, they detoxify the alcohol at about half the rate of adults. But by 3 months, the infant's liver is considered mature. So an estimate is if a woman ingested 4 standard drinks at once and breastfed her infant, the infant blood alcohol concentration would be 0.0049%, so quite low. But remembering that if she did it straight away, you have to wonder whether it would be a bit higher if she actually waited for an hour and a half. This is just how long it takes to eliminate alcohol from breast milk. So this is from the Australian Breastfeeding Association, and women can download this app, and it's a really good app. So it depends on what your weight is. So the heavier you are, the quicker you get rid of alcohol. So you can say, well, I've had 3 standard drinks and I weigh 50 kilos. So it's going to take 5 hours and 35 minutes to get rid of that alcohol from my system. So this is a really good way for women to determine that they can still breastfeed, but how can they do it safely? So a lot of women will say, oh, I'll just express the alcohol out of my breast milk and throw it away, and then everything will be fine. But because the alcohol just goes straight back into the breast milk, expressing or pumping and dumping does not reduce or accelerate alcohol reduction. But food does delay alcohol levels in breast milk. And breastfeeding after 1 to 2 standard drinks can decrease the infant's milk intake by 20 to 23%. So that's quite a lot. If you're having quite a few drinks on a regular basis, your baby's actually not going to get the full feed. So 20% it reduces the amount of milk ejected from the breast, so because it inhibits the letdown. And there are also studies that say that alcohol in breast milk can cause disrupted sleep cycles in babies. And some studies have shown that sedation, altered milk taste, heightened crying and startle reflexes in infants after milk exposure, alcohol and milk exposure has occurred. So with heavy drinking and breastfeeding, evidence has shown that heavy drinking in the postpartum period is associated with an increased risk of death, and certainly around SIDS deaths, babies, people sleeping in their beds with the baby when they've been drinking, not just heavily, any sort of drinking, can increase the risk of SIDS just because people are not as alert to their babies crying and can lie on them and can suffocate them. So there was one episode of an 8-day-old infant where the mother drank 750 mils of port wine in a 24-hour period and breastfed her baby. And that infant's condition was described as being deeply unrousable sleep with snoring, deep respiration, no reaction to pain, inability to suck, and excessive perspiration and a feeble pulse. So this child was obviously very unwell and got a very serious dose of alcohol in the breast milk. And in a 4-month-old baby, the mother was drinking about 10 standard alcoholic drinks a day, and the baby was obese with moon-like face features and a cushion-oid appearance. But this resolved when the mother stopped breastfeeding. So as I said, the NHRMC guidelines are to not drink alcohol until at least 4 to 6 weeks after the baby is born and breastfeeding has been established. The Australian Breastfeeding Association state that casual use of alcohol, such as 1 standard drink of wine will be in a day, is unlikely to cause other short or long-term problems in the breastfeeding infant, especially if the mother waits for 2 hours per drink before feeding. And that they feel that in the event that a woman has consumed 1 or 2 standard drinks and the baby wakes prior to the milk being alcohol-free, that is 2 to 4 hours, that the woman should breastfeed rather than give infant formula. So that's where a woman has fed the baby and then she might have a few drinks, but the baby wakes and she cannot settle it and she needs to feed the baby. And the ABA is saying that basically it is fine to breastfeed with that small amount of alcohol that in the breast milk rather than give infant formula. So what are the recommendations? So eat before and while drinking, breastfeed before drinking alcohol, allow around 2 to 2.5 hours for every standard drink for milk to be alcohol-free, depending on the maternal weight. It's better to breastfeed with a small amount of alcohol in the maternal system than to formula feed. And there is an increased SIDS risk due to maternal drowsiness and co-sleeping. Encourage women to download the ABA app. And it's important for women, if they are going to have a lot of drinks or quite a few drinks, that there is someone at home who is not drinking, who can look after that child and put the child safely to bed, who is not intoxicated. That's very, very important. So when should women be advised not to breastfeed? We can advise women on occasions, but remember that it is ultimately always the woman's decision. So the only people who can really stop a woman from breastfeeding if it's not safe is child protection and the court system. So it's really important to talk to all women about alcohol and breastfeeding, not just wards women, but all women, because alcohol is a very, very big cultural thing that a lot of people do in Australia. And we saw that quite a number of women are breastfeeding while drinking alcohol. Women should be advised not to consume alcohol for the first 4 to 6 weeks postpartum. And women can safely breastfeed if they're drinking low levels of alcohol with an occasional use and following the recommendations. So women really should not be drinking every day while they're breastfeeding, and they should not breastfeed and drink alcohol at all if the baby is premature. And heavy drinkers should be advised not to breastfeed. So, and then that brings us to formula feeding. So often people feel very, very guilty that they are not breastfeeding, because there is a big push in hospitals and from a lot of health professionals to breastfeed, but we have to be very mindful that not everyone can breastfeed. Sometimes it's not safe. So it's very important to try and alleviate that guilt. But we certainly always encourage things to get in contact and touching and encouraging attachment, holding the baby close eye-to-eye contact like they are breastfeeding, but they're not breastfeeding, but those same sorts of contact and skin to skin is important. Sometimes it is safer for the baby when there is substance use for formula feeding. I would say that all women want the very best for their baby. And there are safe alternative nutrition, especially in the first world countries like Australia. So we have a breastfeeding alcohol fact sheet or it's actually alcohol and pregnancy and breastfeeding on our A to Z fact sheets on the Women's Hospital website. So you can go to that if you want to download something to give to patients. And there are some resources as well. So the ABA, that app is very, very good. And next slide. Yep. So I think that's the end. So I suppose just opening up for questions. Thanks, Yvonne.
Thank you. Thank you all very much. I'll just ask you a few questions. I've picked ones where there seems to be a theme. Is the first trimester the most important time not to drink?
I can take that one. The first trimester is the point at which embryonic development is going on. So that's when all the organs are forming, including the brain. So the risk to embryonic development is probably biggest in the first trimester, in that you can cause anatomical differences and structural problems in the embryo via the toxic effect of alcohol. But alcohol is a neurotoxin throughout pregnancy. So the message isn't that the first trimester necessarily is the time to avoid. It should be avoided throughout, but especially in that first trimester period.
Thank you. How do you respond to and have a conversation with a woman who has not planned pregnancy and feels guilty and worried about using alcohol prior to knowing that she is pregnant?
I'll take that one. Very common scenario. And so really it's a discussion about moving forwards and not consuming alcohol moving forwards, and then talking about the fact that having the baby having been exposed to alcohol is an important knowledge for the woman to have, so that she can monitor the baby's development and seek assistance if development is delayed, or if there are any things that come up during parenting that she's worried might be related to the alcohol exposure. So it's really about saying it's not the end of the world, and what's happened has happened, but let's look forwards. Let's look at not having any more alcohol moving forwards, and monitoring the young ones and knowing that if something is awry, that getting help for that sooner rather than later is generally the tenor of conversation that we have. And I don't know if there's anything you would add to that, or Julie?
I suppose it just comes to mind that we've had, over the years, I've been at WADS for about 17 years, but there are a lot of women ring up and ask about this, and they're not just using alcohol, they're also using a lot of other drugs, and possibly for around 3 or 4 months. And some women will go to our genetics people and have genetic counselling, and sometimes people will decide to have a termination. So that also is an option if people are really worried and don't want to go down this track.
Thank you. Next question. I have a client who is 4 weeks pregnant and has just been discharged after a 14-day detox. What should I do first when I reach out to her as her counsellor? She's not made the decision to keep the child or not. Curious how to start the conversation around her choice of keeping or not keeping.
Julie, do you want to take that one?
Well, I think the most important thing is not not to be judgmental, to engage with the woman. What we would usually do is ring her, have a chat to her on the phone, and to try to support her and listen to what she is saying to you. So, and to give her the options, to tell her what the options are. Is she going to also be able to stop drinking during the pregnancy as well? So it's going to be a much more difficult pregnancy if she can't stop drinking. She's just gone to detox. She may be ready for this step. She may not. So it's really all about deciding or working out with her where she is really in that change, we're in the change episode. What do you think, Yvonne?
Yeah. And I would add to that, it's all about, as I mentioned, detox is the first step. What are the plans moving forward? So what does she feel she needs? Does she need to go to rehab, or does she need day hab? Or what are the things that she feels she needs to support her to maintain what she's achieved during the detox? And that's the key kind of conversation around how she's feeling, where she's at, what are the stressors in her life that may be contributing to her drinking. What are the triggers? What is the plan moving forwards to stay off the alcohol? And acknowledging that she's done well to get through the detox, and now we're up to the next stage of addressing this. So really empowering her rather than making her feel guilty in any way.
Thank you very much. Last question. I suspect it's probably for you, Julie, but why is it recommended to feed a baby alcohol that has, to feed a baby breast milk that may be filled with alcohol rather than using formula? It was in one of your last slides. Yeah. Oh, sorry, Anna, are you going to answer it?
I'm going to jump in on this one. Sorry, Julie.
You do, Anna.
Because the benefits of breastfeeding are not just nutritional. And I think that's really important, especially when you're looking at a group of high-risk children. So the benefits of breastfeeding are not just protein and glucose and fat, because, you can get that in infant formula, but what you can't get in infant formula, and what's really important for these babies, is the attentive mothering that comes with a baby who's being exclusively breastfed, in that they're being much more regularly picked up and held and nurtured just by the way that breastfeeding happens compared to formula feeding, which we know in high-risk children can have epigenetic effects that moderate some of the risks children have of high-stress environments in utero. It also confers lots of immune complexes, which are important for protecting children from infection and maturing the gut such that they are less likely to have, for example, allergy in later life. It's protective also against some of those diseases of fetal origin that I mentioned earlier that occur in the state of poor placentation. So obesity, diabetes, long-term cardiovascular risk are all ameliorated, thank you, by breastfeeding. So yes, alcohol in breast milk may be a risk, but infant formula feeding is not without other risk, and those things have to be weighed up appropriately.
I think in that example with which the Australian Breastfeeding Association gave, that woman was only having 1 to 2 drinks. It wasn't that she was having, the 750 mils of port wine, that she was having a very small amount of alcohol. And there is a small amount of alcohol in that breast milk, but as Anna said, there are way more advantages to continuing to breastfeed than to get a bottle of formula.
Yeah, no, our attendee was confused about the kind of mixed messages, but that you've completely answered it. Thank you so much. This will be available on our website shortly, and we hope you've all enjoyed it. Thank you.